The high-stakes scenario. Your patient is suddenly short of breath, clutching their chest, and their oxygen saturation is plummeting. Is it a panic attack or a life-threatening pulmonary embolism that could end in cardiac arrest within minutes? Today, we're bridging the gap between bedside assessment and the high-level pharmacology protocols you need for the NCLEX.
Oh, it is such a terrifying scenario to walk into.
It really is. And before we get into all of it, welcome to this episode of the Super Nurse Podcast. This show is created by Brooke Wallace.
Yeah, and Brooke is just incredible.
She is. She's a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author.
Quite the resume.
Right. Now, I need to be totally clear right up front. I am not Brooke Wallace.
No, you're not.
But today's session is built directly from her bedside knowledge, her personal clinical notes, and her teaching style. We're here to help nursing students and new nurses take all that textbook theory and actually apply it to real patient care.
Exactly. Bridging that gap.
Yeah. And real quick, make sure you subscribe and watch the video version of this discussion on YouTube. The link is right down in the description, and the channel is called Super Nurse AI.
You're going to want to see the video for this one.
For sure. So let's talk about this patient. They're crashing. Their oxygen is dropping. It's really scary.
It commands a lot of respect, right? A pulmonary embolism, or PE, is a true medical emergency. But once we actually break down the physiology of what's happening inside the patient, that fear sort of transforms into focused action.
Right, because we want you walking onto the unit feeling prepared, not like you're just panicking.
Exactly.
So if we look at the mechanics of the lungs, we hear pulmonary embolism all the time, but at its core, this is really a massive supply chain issue.
That's a great way to put it.
Blood flow to a part of the lung is just completely cut off.
Mm-hmm.
And usually, clinical experience shows this is because a deep vein thrombosis, a DVT, has, broken free from the leg.
Yeah, it breaks free, travels up through the right side of the heart, and just slams into the pulmonary artery.
And that structural blockage creates something we hear about constantly on the NCLEX.
Oh, absolutely. The classic VQ mismatch.
Right.
Specifically, it creates what we call alveolar dead space.
Okay, break that down for us.
So when that clot lodges in the lung tissue, the patient is still physically taking in breaths. Ventilation, which is the V part, is actually functioning fine.
The air is getting in.
Right. Air is successfully entering the alveoli. The critical failure is the perfusion, the Q, because that's entirely obstructed by the clot.
I always, I visualize alveolar dead space like a delivery truck full of supplies arriving at a grocery store.
Okay, I like that.
Like the truck is there, the supplies, the oxygen molecules, they're perfectly viable and ready to go. But the store's loading dock has been permanently bricked off.
Yes, exactly.
The oxygen is sitting right there inside the alveoli, but it physically cannot offload into the bloodstream because the blood traffic is backed up behind this massive clot.
That is a perfect analogy. And that structural barrier is exactly what forces us to look backward, at why the clot formed in the first place.
Right, what caused the backup?
Exactly. Evidence consistently points us to Virchow's Triad. It's the physiological foundation of thrombus formation.
And that's three specific things, right?
Right. Venous stasis, endothelial injury, and a hypercoagulable state.
Okay, so venous stasis.
That's simply blood that isn't moving. Stagnant blood is basically a breeding ground for platelets to pool and clump together.
Which is why we worry so much about immobilized patients.
Yes, absolutely.
Like someone on prolonged bed rest or, a patient who just got off a 12-hour international flight. Their blood is just pooling in their lower extremities.
Exactly. But even if the blood is flowing properly, damage to the vessel wall itself, which is the endothelial injury part, that can trigger the exact same clotting cascade.
Because the body is trying to fix the damage.
Right. The body senses that internal trauma, maybe from a recent orthopedic surgery or an abdominal procedure or just major physical trauma, and it rushes clotting factors to the site to patch it up.
Makes sense. And the third piece?
A hypercoagulable state. This means the blood's chemical composition is just thicker and inherently more prone to clotting.
And we see that a lot in certain populations, right?
Yeah, we frequently see this altered blood chemistry in pregnancy or in patients taking oral contraceptives that contain estrogen.
Okay, so if a patient has those risk factors and a clot successfully navigates up to the lungs, the danger isn't just in the respiratory system.
No, not at all.
The right ventricle of the heart is suddenly in severe jeopardy. I mean, its entire job is to pump deoxygenated blood into the pulmonary system.
Right.
So if a massive clot is blocking the pulmonary artery, the right ventricle is suddenly pumping against a brick wall.
It's mechanical resistance, and
Mhm.
it causes severe right ventricular strain. The heart muscle has to work exponentially harder to push blood past that obstruction.
Which sounds incredibly dangerous.
It is. It can rapidly dilate the ventricle, leading to acute right-sided heart failure, decreased cardiac output, and ultimately cardiac arrest.
Wow. And that mechanical failure of the heart brings up a really fascinating and honestly deeply unsettling bedside presentation.
Oh, the feeling of impending doom.
Yes, you're standing in the patient's room and they look at you with these wide eyes and literally say, I feel like I'm going to die.
Yeah, it chills you to the bone.
It sounds purely psychiatric, like a panic attack, but it's actually a severe physiological alarm bell. Why does a blood clot cause that emotional reaction?
Because the brain is highly sensitive to changes in blood flow and oxygenation. When the central pump starts failing and oxygen levels just crash, the brain recognizes that the body is losing a fight for survival.
You know something is terribly wrong.
Exactly. It triggers a massive systemic sympathetic nervous system dump. Adrenaline just floods the system.
So it's not just anxiety.
No, not at all. The patient's central nervous system is accurately reporting that their life is actively ending.
Which translates to a critical rule for bedside nursing. You never, ever rush off a patient who tells you they feel like they're dying.
Never.
You don't document it as a mild anxiety attack and just walk away to grab them a warm blanket. You investigate the physical vital signs immediately because the patient is telling you their right ventricle is failing.
And taking immediate action is non-negotiable here. The bedside nurse has to pivot instantly. Priority setting is everything in those vital minutes before the provider reaches the room.
Right, so let's get into those priority actions.
Yeah.
Because the NCLEX loves to test what you do first.
Oh, they do.
And while it might be super tempting to, like, start an IV or call the doctor or assess their chest pain on a scale of 1 to 10.
Don't do that.
Right. The textbook and the real world align perfectly here. You go straight to the ABCs: airway, breathing, circulation.
You apply oxygen immediately, and we are talking high-flow oxygen via a face mask, like a non-rebreather.
No nasal cannulas here.
No, they need high flow. Simultaneously, you elevate the head of the bed into a semi-Fowler's position.
Okay, why that specific position?
Well, by raising the head of the bed roughly 30 to 45 degrees, you drop the abdominal organs away from the diaphragm. This maximizes the physical expansion of the lungs.
Because oxygen isn't just a basic intervention in this exact moment, right?
Right.
It's literal life support.
It really is. It directly combats the severe hypoxemia and helps reduce the myocardial strain on that struggling right ventricle.
So we never delay oxygen to assess pain or wait for a provider's official order.
Never. Securing the airway and oxygenation always comes first.
Okay, but alongside that physical intervention, there's a psychological component that I think often paralyzes newer nurses.
Yeah, the communication piece.
Exactly. When your patient is clutching their chest, gasping for air, and screaming that they are dying, the instinct is to just offer comfort. You want to say whatever makes them stop panicking.
The urge to say, you're going to be fine, the doctor's on the way, is overwhelmingly strong.
But the golden rule of crisis communication dictates a very different approach.
Yeah, it does. The precise NCLEX approved and clinically effective response is to look them directly in the eye and state firmly, I will stay with you until the physician comes.
Just that. I will stay with you.
Just that. That phrase provides therapeutic presence. It guarantees physical safety and emotional grounding without making empty, unkeepable promises.
Because offering false reassurances actually invalidates their fear.
Right. You don't actually know they are going to be fine. And the patient's brain, which is in total survival mode, knows you are lying to them.
That makes so much sense. It's also equally dangerous to ask why questions, right? Like asking a gasping patient, why do you think you're dying?
Oh, absolutely. That puts them on the defensive. But more importantly, a patient who is struggling for every single breath does not have the oxygen reserve to explain their existential dread to you.
They literally can't afford the oxygen to speak.
Exactly. Calm physical presence and purposeful, decisive action, like securing that oxygen mask and positioning the bed that creates true psychological safety. You're showing them that you are in control of the environment when their internal environment is in complete chaos.
Wow. All right, so the oxygen has bought us a few precious minutes, maybe stabilize their heart rate a bit.
Mm-hmm.
But we can't fix what we can't see.
Right.
How does the medical team pinpoint where this clot actually is? Let's talk about anticipating the provider's orders.
So the diagnostic sequence usually starts with blood work. The provider will almost certainly order a D-dimer test.
Okay, the D-dimer. That gets thrown around a lot in nursing school. But fundamentally, it's just measuring microscopic debris, right?
That's exactly what it is. When the body tries to break down a clot naturally, it leaves behind cross-linked fibrin degradation products.
Like crumbs after a meal.
Great way to think of it. The D-dimer test is just a sweep of the blood to see if those specific fibrin fragments are floating around.
And what's the baseline we're looking for?
A normal D-dimer is usually less than 0.5. When it comes back elevated, it serves as a massive red flag.
So it confirms there's a clot.
It confirms that the body is actively trying to dissolve a clot somewhere in the vascular system. However, and this is key, it does not point a neon sign at the pulmonary artery.
It just confirms the presence of clotting activity generally.
Right. Because it lacks that specific location data, we have to look to imaging. The gold standard for actually diagnosing a PE is a CT chest with angiography.
Okay. Would they ever order just a normal chest x-ray?
They might order a standard chest x-ray first, just to rule out a pneumothorax or pneumonia. But the CT angio uses 5E contrail dye to light up the pulmonary vessels, highlighting the exact location and size of the blockage.
And the nurse's role during this phase is highly logistical, right? You have to facilitate getting a highly unstable, hypoxic patient down to the radiology suite quickly.
Without ever compromising their oxygenation. You are managing the portable travel monitor, ensuring the oxygen tank has enough PSI for the trip, and protecting those IV lines.
That's stressful. So once that CT scan confirms the pulmonary embolism, the care plan shifts entirely. Immediate medical intervention is required to stop that clot from growing.
Which brings us to the high-stakes pharmacology protocols.
Yes. We need to talk about heparin, and specifically, we really need to dismantle the Pac-Man theory.
Oh, I'm so glad you brought this up. The Pac-Man theory is such a pervasive myth.
It really is. Students think heparin is this little guy eating the clot.
Right. Many people assume heparin is a clot buster, visualizing it swimming through the bloodstream and actively chewing up the existing clot in the lungs.
But if heparin isn't a Pac-Man dissolving the clot, what is it actually doing? Because the underlying mechanics tell us it acts more like a biochemical roadblock.
Exactly. The evidence shows us that true clot busters are medications like TPA tissue plasminogen activator, which are thrombolytics, or physical removal via surgical embolectomy.
So heparin just halts the process.
Right. It acts as a roadblock by binding to a naturally occurring protein in the blood called antithrombin 3, or AT3. By altering the shape of AT3, heparin supercharges the body's ability to inactivate specific clotting factors, primarily thrombin and factor XI.
So it essentially cuts off the supply of fibrin, the sticky protein that acts like a Band-Aid, preventing the clot from getting any larger.
You've got it. By stopping the growth, heparin buys the body time. The human body has its own natural fibrinolytic system that will slowly break the clot down over days or weeks.
But managing that heparin roadblock requires a continuous IV drip, and it is an intense, high-alert process.
Very high alert.
Yeah.
Dosing errors with IV heparin can cause catastrophic, fatal hemorrhages. That is why it always requires a dual nurse sign-off.
2 licensed nurses checking everything.
Always. 2 nurses must independently verify the patient's weight, confirm the drug concentration in the IV bag, and double-check the pump settings before hitting start.
And the monitoring is relentless. It relies on a specific lab value, the PTT, or activated partial thromboplastin time.
Right. This lab measures exactly how many seconds it takes for the patient's blood to form a clot.
So you draw a baseline PTT before initiating the drip.
Right. Yes, but you aren't basing your initial dosage on that number. You simply need a starting reference point. Once the drip is running, standard protocols require a new PTT draw every 6 hours.
Every 6 hours.
Every 6 hours or 6 hours after any rate change.
And you adjust that rate using a sliding scale protocol. Because the goal isn't to stop clotting entirely, but to delay it safely.
Exactly. We want a therapeutic range.
What's the target there?
The target therapeutic range for a PTT is generally 1.5 to 2.5 times the normal control value. In most hospital settings, that means we want the blood to take between 60 and 80 seconds to clot.
Okay, so the sliding scale gives the nurse specific parameters. If the lab comes back and the PTT is, say, 95.
That means the blood is taking too long to clot. The blood is too thin, placing the patient at a severe risk for spontaneous bleeding.
So the protocol would instruct the nurse to pause the drip for a set time or decrease the hourly rate. Conversely, if the PTT comes back at 45, the blood is too thick, and that pulmonary embolism could be actively growing.
Right, and in that case, the protocol will likely instruct the nurse to administer an immediate IV bolus of heparin to flood the system and then increase the continuous drip rate.
It is such a delicate, continuous balancing act.
It is.
But while we are meticulously managing the PTT, we must also monitor the patient's platelet count, because heparin therapy carries the risk of a terrifying paradoxical complication known as HIT.
HIT, heparin-induced thrombocytopenia.
When does that usually show up?
It typically emerges 4 to 10 days into heparin therapy. The body essentially develops a severe immune-mediated allergic reaction to the medication.
An allergic reaction that destroys platelets.
Basically, yeah. The immune system forms antibodies against the heparin platelet complex. This autoimmune response rapidly destroys circulating platelets, causing the count to drop dangerously low. That's the thrombocytopenia part.
But that's not even the scariest part.
No, the true danger lies in what those antibodies do next. They activate the remaining platelets, throwing the patient into a highly prothrombotic state.
So the body starts generating thousands of new deadly microclots systemically.
Yes.
Everywhere.
Okay, wait, let me challenge that protocol. If I'm looking at a lab report and I see severe thrombocytopenia like crashing platelets, standard clinical logic dictates we replace what's missing with a transfusion.
It does seem logical.
Right, if the platelets are gone, why wouldn't we just anticipate an order for a platelet transfusion?
Because doing that in a patient with HIT is disastrous. Giving fresh platelets to a HIT patient is like throwing gasoline on a fire.
Wow, really?
Yeah. It's like delivering fresh bricks to a rogue construction crew. The body isn't going to use those platelets to fix bleeding issues. The rogue antibodies will instantly hijack those new materials to build hundreds of new deadly blockades in the brain, the kidneys, and the liver.
That is wild. So the underlying problem isn't a supply issue, it's that the body has literally weaponized the supply. Exactly. The correct intervention requires stopping the physiological cascade at the source.
So you immediately stop all heparin exposure.
All of it. This includes the IV drip, subcutaneous injections, and even heparin flushes for central lines. You alert the provider, and you prepare to transition the patient to a non-heparin direct thrombin inhibitor.
Like what?
Usually an argatrobin continuous IV drip. That manages the active clotting without triggering the antibodies?
And as a safety net, the nurse must ensure protamine sulfate is readily available, right?
Yes. Protamine sulfate is the specific chemical antidote for heparin.
Does it work fast?
Very fast. It binds to heparin and neutralizes its anticoagulant effects in about 5 minutes.
Oh, wow.
But administration requires extreme caution. You have to push it slowly. IV typically no more than 50 milligrams over 10 minutes.
Because if you push it too fast...
Pushing it too fast can precipitate severe hypotension, bradycardia, and total cardiovascular collapse.
Right, so assuming the patient navigates the acute phase without developing HIT, they eventually need to transition to home care.
Yeah, we use what's called the golden sequence of long-term anticoagulation.
Golden sequence. Break that down for us.
So they use the IV heparin drip for rapid acute stabilization in the ICU. Then they bridge the patient to a subcutaneous low molecular weight heparin like Lovenox. Finally, they transition to a daily oral medication like warfarin for long-term home maintenance.
It's a really complex journey requiring intense patient education. But the reality of bedside nursing is that blood clots are only one type of embolism.
True.
We have to be equally prepared for materials other than blood entering the pulmonary artery, which require completely different physical interventions.
Yeah, that's where things get really interesting.
The idea that not all embolisms are blood clots brings up a scenario that is the stuff of nursing nightmares.
Oh, I know where you're going with this.
Yeah. You are removing a central IV line from a patient's internal jugular vein. As you pull the catheter, you suddenly hear a distinct hissing or kissing sound of rushing air.
The worst sound you can hear.
Instantly, the patient's eyes go wide, and they give you a terrifying, unresponsive stare.
Because you have just caused or witnessed an air embolism. A significant volume of room air has been sucked through the open catheter tract directly into the patient's central venous system.
And that air bubble travels straight to the right side of the heart and into the pulmonary artery.
Exactly, acting exactly like a massive blood clot when it hits the lungs.
So you don't have time to wait for labs or a heparin drip here. You have literally seconds to intervene mechanically.
Seconds.
The immediate life-saving bedside actions dictate that you instantly clamp the line or cover the insertion site with an occlusive dressing to stop the air intake. Then what?
Then you immediately place the patient in the left Trendelenburg position.
Left Trendelenburg.
Explain that. Means rolling the patient onto their left side and tilting the entire bed so their head is lower than their feet.
And the why behind this specific position is purely based on gravity.
Right. Exactly. By positioning them head down on their left side, the physical air bubble rises and gets trapped against the apex of the right ventricle and the right atrium.
So you are creating a physical trap.
Yes.
It holds the air bubble inside the heart chamber, so it physically cannot be pumped out into the pulmonary artery.
Which buys the body time for the trapped room air to slowly reabsorb into the surrounding bloodstream.
It is brilliant mechanical bedside medicine.
Yeah.
And we see a similar divergence in presentation when we look at fat embolisms.
Oh, definitely. These typically present following a major physical trauma.
Specifically a long bone fracture, right?
Yeah.
Such as a femur or pelvis.
Right. The yellow marrow inside those long bones contains heavy concentrations of fat. When the bone splinters and breaks, the trauma forces those fat globules into the ruptured local blood vessels.
And they travel the same venous highway to the lungs.
They do, but they present with distinct clinical markers. The patient will exhibit the acute shortness of breath and hypoxia associated with a standard PE. But uniquely, they will also present with acute confusion. Because the fat microemboli often pass through the pulmonary capillaries and enter systemic circulation, showering the brain and causing rapid neurological decline. Furthermore, they present with a petechial rash.
Ah, the petechial rash. That's the hallmark sign. Those tiny pink or purple spots suddenly appearing on the patient's chest, neck, or axilla.
Yeah. The fat microemboli actually block the tiny capillaries in the skin. That microscopic blockage causes pressure to build until the capillary ruptures, leaking red blood cells into the surrounding tissue and creating those distinct spots.
So if you are caring for a patient post-motor vehicle accident with a fractured femur, and they suddenly become restless, hypoxic, and break out in a pinpoint rash on their chest,
your clinical judgment should immediately suspect a fat embolism syndrome.
it is incredible how the presentation shifts based on the material of the clot.
It really is.
I want to bring our discussion back to the most common culprit we discussed earlier, the deep vein thrombosis in the lower leg. I often compare massaging a swollen DVT-filled leg to aggressively shaking a tree full of loose apples.
That's a great analogy. The mechanical risk is identical. If you shake the tree, you guarantee the apples are going to detach and fall.
Which perfectly highlights a critical safety difference that the NCLEX tests relentlessly, the stark contrast between DVT prevention and DVT treatment.
Very different things. For DVT prevention, meaning the patient is high risk but does not currently have an active clot, our goal is eliminating venous stasis.
Keep the blood moving.
Right. We advocate for early and frequent ambulation. We also utilize sequential compression devices, or SCDs.
Those are the sleeves that wrap around the legs?
Yeah, they periodically inflate, physically mimicking the natural muscle contractions of walking to keep the blood flowing back toward the heart.
But the moment a DVT is diagnosed, meaning we know there is a fragile active clot sitting in that deep vein, our interventions completely reverse.
Completely. You transition to strict bed rest. You immediately remove and discontinue the sequential compression devices on the affected leg. And you absolutely never massage the calf.
Never.
Just like shaking the apple tree, massaging the muscle or applying mechanical compression will instantly dislodge the fragile thrombus, launching it directly into the vena cava and up to the lungs.
Understanding the specific mechanism there isn't just about passing a licensure exam. It is literally the difference between preventing a complication and actively causing a fatal event.
It really is.
We have covered a tremendous amount of high-level physiology today. The goal is to realize that understanding the why behind these intense protocols strips the fear out of critical care.
When you comprehend why a D-dimer elevates or why fresh platelets are lethal during HIT, you stop relying on rote memorization. You begin anticipating the physiological cascade.
And that is the hallmark of an exceptional bedside nurse. You are learning how to think, mapping textbook theory directly onto the crashing patient in front of you. I want to leave you with a final thought to ponder before your next shift. We discuss how the human body comes equipped with its own natural, intricate fibrinolytic system, a system that can eventually break down massive, life-threatening blood clots completely on its own, provided our heparin drip can halt the new growth.
Right.
So it makes you wonder how much of high-stakes critical care nursing is ultimately just about buying time. Are we genuinely fixing the patient with all these intense pharmacological interventions, or are we meticulously protecting the patient from their own internal cascades while their natural emergency responders do the heavy lifting? Keep that perspective in mind the next time you initiate a heparin protocol.